Welcome to part 3 of examining the anterior approach from down under. Let's get back to the last portion of our conversation with Australian hip surgeons Patrick Weinrauch, Ilan Freedman, and Jit Balakumar, as well as orthopedic sales rep Joe Scerri. Speaking of things that have sort of changed how you look at or how you think or how you learn in your surgical approaches, what would you, if we can go around to each of you, but what would you say have been the single sort of biggest disruptors in your practice, whether it's an actual practical technique that you've learned around anterior approach, an implant, or a new piece of technology that's really changed or improved the way that you've done anterior total hips?
Yeah, no single technology. I think, I think using fluoro, and then I think there's a whole lot of fluoro-based systems, whether it's Verifier or Velis or whatever. I think, I've changed incision from longitudinal to bikini. But these things are chasing the 2% improvements. I don't think there's been a single element of anterior that's changed. I looked briefly at off table, went back to what I knew. But little things that make sort of, marginal differences. I use a special skin sealant. So just, we're chasing the 1%ers now. There's no single thing that's really revolutionized my anterior approach specifically.
Mine's not surgical. So I'd say the incorporation of low-dose spinal, right? So low-dose spinal has really made a big difference to my patients' first 24 hours and their experience of the surgery. A spinal where they're able to still walk straight away and to be able, they haven't lost motor function, yet they don't need big doses of opiates, and they're really comfy and they've got no nausea. And they don't get, they get less constipation and all that sort of stuff. So I think for me, if I look at the one thing that's really made my patients most happy, because listen, I do lots of posterior approaches too, you see, and they both go really well, right? And I suppose that leads into the second thing, if I'm allowed a second disruptive technology.
Of course.
The second disruptive technology is just the change in mindset of our teams, right? Where we've got teams of therapists and nurses who are willing to be able to get people mobilized, early, and they've got, they're quite used to dealing with all of the, any of the problems that people might see in the perisurgical period, yet still push on with good rehabilitation. And so that mindset that you don't have to lie a patient in bed for like the first 24 hours, that's like, so if I've got two, it'd be the spinal and it'd be the team, right? It's actually like, for me, it's probably not the approach.
Yeah.
Yeah, no, I'd say having a regular team. So I was working at a hospital where every theatre list would be a different team. And I think anterior approach it's intense for the surgeon, but also pretty hard for the scrub nurse if they're a newbie. So I think hospitals which have recognized giving you a consistent scrub team who know your instruments, having a company rep which doesn't change every week. Just getting. I agree with Pat that the team is beyond just the surgeon. There's so many sub teams within the anterior approach which are very important.
Look, I think the table. I've been using the HANA table since Dr. Marta convinced me to his benefit. We've got about 3 of those tables in our hospital. So, and I love it. I've tried for J&J, I was like the KOL for off table for the whole of Asia Pacific. And it was just the most unpleasant experience with, 140 kilo, 160 kilo patients. It's not fun, but look, it's each of them have its own benefits and disadvantages. But I think the table for me is a big disruptor. And I think, 3D planning to me is a big, big change. Only I would say, we all know, total hip operation of the century, 95% improved patient outcomes, 60% forgotten hip. But I'm confident that either through experience or through impeccable planning, 3D planning, my bandwidth of forgotten hip is increasing. And particularly in the anterior approach, I'm learning, actually, you know what? I'll probably change their anterior offset, reamed a bit more anteriorly. Now on focusing on reaming into the right pillar. I was obsessed about getting rid of the psoas impingement by tucking the cup in deep, but you can get extra articular impingement, which I wasn't appreciating as much with just dynamic examination. So I think that 3D planning really gives you that extra bit of information. And to me, that's a big disruptor.
How are you guys incorporating your team in the learning portion of the approach? How are you bringing a team up to speed?
I think, first of all, the company which I've had referenced, which was sending surgeons education, was also sending the reps. They put a lot of investment into trying to educate not just their team, but their sales team. And then it's up to the surgeon we run what we call in-services, where you'd be running a little mini workshop for your team, and the company would bring the gear and the stuff, and you have to just give the time to go through the trays and to workshop those cases, and to also be a bit pushy initially that you wanted a consistent team. The hospitals didn't necessarily give it to you the first time you asked for it. Ironically, the more senior the surgeon, the better the team. So you had a situation where when you're a very junior surgeon, without much experience, you'd get the least experienced nursing team, which makes no sense. It should be flipped the other way. But having enough, I guess, say in the hospital to get the team that you want and to spend the time educating them.
Ilan, as you become the more experienced surgeon, are you willing to give up the experienced team for the less experienced one?
Yes, I should be, but no, you hang on to what you've earned. But it is a bit ironic that the new surgeon in the hospital gets the least experienced nurse. But
that does bring up an important point, though, is that say, for instance, when I do have someone come and visit and they want to learn anterior approach, and they see it, and they've done a couple of visitations. They're sort of at that point of getting ready to pull the trigger, and they sort of ask me, well, how do I incorporate this seamlessly into my practice, or with the minimum amount of turbulence? And I think that you've got to think of the surgery as a team sport, right? And so you've got a mental model of what you want it to look like because you've seen it and you've trained it and you've thought about it, you've read about it, and you've been on visitations and you've done a certain amount of training. But the rest of the team, none of them have seen it, right? So you haven't got a shared mental model there, right? And so to be able to achieve that, you've got to deliver some form of education to them. And I think the best way in which you can achieve that is to bring your key people with you when you're learning, right? So if you go to a cadaver lab, if whoever's running the cadaver lab will allow them to be able to bring, for instance, your first assistant or your scrub sister, right, or your scrub staff, then they can see that, right? So, and we've had visitations where they've brought in like the lead scrub nurse, right, and because when they come in and see the procedure, the surgeon is focused on do this, release that, do this, do that. But the scrub sister's looking at the flow and they're seeing how they drape and, which bits of equipment they need and and so when it comes to the time of actually needing to do the surgery in their new place, the thing that's going to be the hardest is the surgeon walks in and he goes, oh, well, let's whack some drapes off. But I wasn't really taking much attention to all of those little things that the other members of the team, that's their world, right? And they see that stuff, right? And they grab it and then they transplant it in. And so, because we're so focused on what we do, right? Yeah. So I think the key point out of that is that if you can get some form of education for your staff around you, and that's how I introduced it into my practice. I had my lead surgical assistant, who happens also to be a nurse, come with me, and then she was able to not only assist me, so there was a buddy system there, but also she was able to very easily translate that over to the other staff to be able to say, right, this is what you need to do, right, in a way in which I wouldn't have been able to articulate myself.
The issue is, for me, this is the ideal situation. Teamwork is dream work. I'm sure you've all heard Christoph Corton talking about the efficient anterior approach. And he did this great talk about how many minutes he's saved in a day. that's translated to how many years it saved in his life, right? And it made me very depressed.
At least you're not waiting
Right?
for. At least you're not waiting for cement to set.
What I realized is that every 3 years, my table technician moves on to becomes a rep. They join some company, right? Oh, my nurses get pregnant, or if they can't get pregnant, they move on. And I always say, look, in our hospital, I refer to the surgeons as the big five, like in the game parks, and I'm just a hyena, jokingly, knowing that secretly I'm in the big five. But you want to, I think you have to be open to the idea that it's not like it used to be. Everyone's moving, people have ambitions. The really good staff that we have actually, after some time, want to move on, right, to something else.
Yeah.
And it's a very hard thing to be able to do that. And I think what I've actually got a lot more of is patience. I've just realized I'm no longer getting frustrated, and I want to be more like Roger Federer when all those unforced errors happen, and not like Nick Kyrgios, because when I see that new member of nursing staff in my theater, I don't want to be smashing that racket on the floor, right? And so I would say, look, I agree with everything that Pat and Ilan are saying, but I have a different experience. I'm getting to the stage where I'm like, oh my God, how did this happen all of a sudden? And, there's some completely new member of staff in my theater, or on the ward, there's a physio who says, oh yes, let's start using the walking frame. And don't sit and bend over more than 90 degrees. That's like, what's happened here? How did that happen? And I don't. Are you guys seeing that at all, or not really? Maybe I'm the only one who's just getting all this change in staff.
No, I think that having I think the benefit of having a high volume practice though is that people can learn things pretty quickly because they just get repetition really fast, right? So, and if you're doing enough volume, there's sort of a critical mass where, or even if they're not your regular staff, even your irregular staff have now had the opportunity to be able to do lots of them, right? So there's like depth in the team. So if you have a complete stranger come in, you know that you're surrounded by lots of people who aren't complete strangers, right? So there's enough, you can accommodate it. So we can have 2 new staff come in, right? That's fine. We do that all the time, and pretty quickly they learn the ropes because there's enough resilience in the system to be able to compensate for that. Yeah, I think that's probably one of the I suppose tagline benefits of having a reasonable volume practice too. Yeah.
I was going to say the big thing that I've noticed is if you go back maybe 15 years, a surgeon would change an implant and nothing else would change around him or her. Whereas now, if you go to your question, Joe, a direct anterior, suddenly you've got to change the draping. To Ilan's point, you might need to use fluoro or you may not. You may want to use a table, you may not. You're going to need a bunch of different retractors, you may or may not. You might do the figure 4. And so all of those things have now changed as distinct from just changing from a porous coated stem with HA or one without, or a polished stem and maybe using cement. Whereas now suddenly all these people that are involved in you having a successful outcome, there's a lot of moving parts. And what I've noticed, in the last few years is just the amount of laptops that are in theatre now looking at screens and, what degree is that and what angle is that? Whereas back in the old days, you were lucky sometimes if someone did pre-op plan with a template, it's, what are you planning? What's the strategy today, doc? And it's like, well, I don't know. I haven't seen the x-ray yet. And so, we've come a long way, and that's credit to the industry, and people are getting that great attention. And also it was like back in the day, it was, well, what clinical history do you have? And now it's more about how you put it in rather than what you're putting in.
Gentlemen, I want to thank you for taking time to talk with me today. And thank you for helping educate our listeners. And of course, thank you for everything you do for your patients. If you're interested in learning more about today's guests, you can check out our show notes for their practice links. Join us every Friday for a new episode of the AHF podcast. You can find us in audio form in your favorite podcast app or watch our video podcast on YouTube. Don't forget to like and subscribe and leave us a 5-star review to help us reach a wider audience and to keep this content coming. Until next week, this is Joe Schwab reminding you to keep those hips happy and healthy.